Yeah, I'm joking. But just I got.
Nkutambise nkulaba wano gwe Cherezov.
One of the presenters at the
Hello, good afternoon, Dr. Kisembo, and good morning, Dr. Dmitrii. Thank you for logging on in time.
Good afternoon.
Hello, how are you?
Hello. Good
Thank you
afternoon.
for keeping time.
Yeah.
Okay. So we'll allow the rest of the colleagues joining us to log on.
Sure. I think at least we have 5 minutes more.
Yes, true.
Who is presenting first?
Dr. Dmitrii will go first.
Okay.
Wherever.
Then we'll have Dr. Harriet after, and then we'll keep the discussion and the questions and comments for the end when both of you have finished presenting.
That's fine.
Okay. Good afternoon to you all. I welcome you to this month's Day of Lung Science. Thank you for logging on for this discussion. I kindly request that we allow a few more minutes, maybe 5, to increase the number of people logging on so that we can start. Hopefully we should be starting in the next 5 minutes. Okay, so once again, good afternoon. I think in the interest of time, we're going to start. The rest of our colleagues that will be joining us will get us along the way. My name is Sharon Namiiro. I'll be chairing today's Day of Lung Science session. I am a physician and a research fellow with the Makerere University Lung Institute. And like I mentioned, I'm going to be chairing this session. I'd like to welcome our presenters that I'll be introducing shortly. That's Dr. Dmitrii and Dr. Harriet Kisembo that will be sharing their wealth of knowledge and skills in this area with us. On housekeeping, I'd like to request that we all keep our gadgets muted unless we are presenting or given a chance to speak up. We are going to reserve the comments and the questions and additions that we'd like to make for the end of the session when both the presenters have completed their presentations. But for those that would like to share their questions as we go along, please keep them coming through that chat. We'll look at them as well. But those that would be like to be given a chance to speak up, this will come at the end of the two presentations. And then, so you feel free to use the chat or raise your hand when you want to be given a chance to speak. And then we'll have a CPD link that will be shared as we go on. It will be shared in the chat. Please remember to register your attendance for us to be able to get your CPD points updated. And then, so just to take us quickly to why we are here today. So today's Day of Lung Science is focusing on artificial intelligence in lung cancer imaging. We're basically going to share about the role of artificial intelligence in lung cancer screening, how it can be used to improve screening of lung cancer, especially detection of lung cancer nodules, how it can help to reduce false positivity rates, and ultimately improve the overall diagnostic accuracy for lung cancer. And we're also going to be able to appreciate how artificial intelligence can work alongside radiologists to be able to facilitate early detection of lung cancer among patients, as well as improve the patient's outcomes. Mainly that's what we are going to discuss today. I mentioned earlier that we have two presenters that we are lucky to have on the call today. And our first presenter, so I'll introduce the first presenter as we start, and then I'll introduce the second presenter when her presentation is coming on. So our first presenter, we want to appreciate you, Dr. Dmitrii, for accepting to take off time. We know that you have a very busy schedule, but we appreciate you having taken off time to be a part of this discussion today. And Dr. Dmitrii is a Post-Doctoral Fellow with the Department of Radiology and Imaging Science from the Emory University School of Medicine, Atlanta, Georgia, USA. He holds an undergraduate degree in programming and information technology, as well as a master's degree in intelligence systems and a PhD in computer science from the University of South Florida. I mentioned he's a postdoctoral fellow currently with Emory University, and he's also a research associate at Case Western Reserve University. So he's also currently supporting the AI component of the lung cancer project that we are conducting at the Lung Institute, as well as the National Institute of Medical Research, Muhimbili, Tanzania. And for today, he's going to take us through the general overview of artificial intelligence and how artificial intelligence works. So you're welcome, Dr. Dmitrii, and over to you to start your presentation. Thank you.
Thank you, Sharon, for the introduction. So the first question, do you see my screen? Do you see the presentation?
Yes, we can see your presentation. Thank you.
Okay, thank you. Well, hello, everybody. And yes, I'm talking today about AI in medicine. And as I understand, most of the people know only back end of the AI, so simply like using this in their research, maybe using this in the research, but what I want to talk about this, the perspective, what I want to talk about this is that kind of what's going on behind the scenes, so how it's working, because without understanding, for example, how the AI see the medicine, how it sees the medical images, it's almost impossible to design a useful working model. So the goal of my presentation today is again reveal the secret of the AI, so how it's working, and show the difference between AI and clinicians, with in the conclusion to highlight important aspects for the AI research. So first of all, the definition of artificial intelligence was introduced by Professor John McCarthy in 1956, where he's defined artificial intelligence as a use of computers and technology to simulate intelligent behavior and critical thinking comparable to human beings. So first of all, it's important to understand the particular words like simulate. Simulation implies replication of condition and characteristics or behavior of something for further study and analyzing. And it's different from replication, where it means to reproduce or make exact copy of something. So AI is not replicating clinician when it's used in the medical thing. It's simulate its behavior. And that's important part first to understand. Second, it's need to understand that artificial itself is a quite of a broad definition. It applies multiple aspects and it consists of particular structure. So as I said, generally, we have artificial intelligence. It's simulation of intelligence. Deeper, we have a machine learning. So machine learning involves particular algorithms. For example, statistics, which we make with which we make computations, and as a result, we make some decisions or predictions based on data which we observed. And the deeper, we have a deep learning. So deep learning is using artificial neural networks, which we will talk about later, so for making these decisions. So AI, mainly what we're going to talk is called data-driven decisions. So it has a particular step when it says training. So training requires a pair of data and the corresponding decision. So for example, we have an image, we know the diagnosis. We have clinical data, we have a prognosis, something. We need, overall, we need to know input data and what should be the output for our model. So what should be the decision? So the first thing to understand how it's working, basically what the model trains to do, it, among the data, finds some conditions and some decisions and making directly or indirectly particular rules that if data satisfies particular condition, then we have decision one. If there is another condition, there should be a different decision. And here we come at the first kind of difference. So here, when we do such kind of a training, it does not involve domain knowledge anyhow. So AI does not know about medicine, nothing. It takes data, it takes a decision which it should be done, and it simulates this decision, but it still doesn't know what the medicine is. The second outcome from such definition of the training is that results of training may change with the change of the data set. So that's why, again, it's called data-driven decisions. One of the example here could be long-read guideline. So it's a guideline for long screening imaging where it has a particular definition of criteria. So for example, nodule longest diameter observed on a long screening, and it helps to assign risk score groups with respect to observed characteristics. So immediately, I can write any model, or even the person without the medical knowledge can say, if the, for example, nodule longest diameter less than 6 millimeters, then the nodule is considered as benign. If the nodule longest diameter more than 15 millimeters, then it's a high risk of the malignancy for the tumor. Again, this particular model works simply with nodules. It does not know what the longest diameter is, how it's computed, how the imaging was done, or anything. So it's with given number in such kind of form simulates work of, for example, radiologists. And we're going deeper. So we are going for machine learning. So one of the things is logistic regression. So maybe some of you worked with this before. So I will go with kind of example that, for example, we have a characteristic of a tumor where we know surface area and the diagnosis based on the surface area. So logistic regression with this data can help us to find a threshold. So at which values of long nodule area we should say that nodule is malignant, or at which values it's benign. So how it's working, it tries to assign particular weights for characteristics. In our case, it's a single characteristics area, but it may work with multiple characteristics. So it will try to find the most important, in our case, it's the single important value characteristic area. And with the statistics, it will find a plotted function where it will define the probability that a particular tumor is malignant or benign. So for example, on the plot here, it's kind of making simple rule. If the area is more than, the wrong side, more than 750 millimeters square, then it's malignant. If it's smaller than 750, then the nodule is benign. So, as I said before, this model doesn't know about medicine anything. It simply knows that there are two groups with different distributions, and it tries to find, given the data, optimal value, how to differentiate these two groups. So that's how the machine learns. Here we coming to more sophisticated approach. So if we took a bit of a mathematics, what the logistic regression is, so it's like it's here showing the function, we have a weights, we multiply characteristics, and then we sum it up. It is considered that it's mathematical model for a biological neuron. So neuron gets some signals, it somehow modifies it and produces the output. Well, with a single neuron, we can do what was simple relationship by defining how important individual characteristics right here, right now. But following biological stream, the more sophisticated way is a biological networks. When we have multiple neurons, a single neuron somehow processes this incoming signal, incoming characteristics of tumor, patients, wherever. Again, neuron doesn't know what kind of signal it's processing. It could be anything. So it's getting input, modified it, and send it to another neuron. By doing such a thing, we replicating this biological model, we are getting artificial neural network. So it's also processing multiple signals from other neurons in order to produce probabilistic outcome. As a model complicates in architecture, it gives a particular benefit. We can have a more sophisticated relationships between the characteristics. As a single logistic regression, it simply corresponds to importance of each characteristic directly to the decision. With this model, we can have a more complicated relationship between the characteristics in order to compute the outcome. With this, we come to the point like how these neural networks were used in the medicine. Well, first, people try to send the entire image as a characteristics, for example, as input to these neural networks in any kind of a question, because as I said before, model doesn't know about the image. It simply tries to associate it with the outcome. But such of a approach of sending the entire image required a lot of computation power, which caused the fact that we didn't see such practical implication until 2014, where we got a GPUs which were able to compute such things fast. Another approach here would be to compute handcrafted features. So we, as the researchers, characterize somehow nodules, and we send it as a small set of characteristics to the network, and network would associate it with the decision. So what, for example, people were computed? So, for example, here you can see an original image, which is some tumor, and that's what, for example, Radiologist says. But with particular characteristics, they define different aspects of a nodule. So, for example, edges. So how sharp the edges are. It's one of the characteristics. Then, for example, by applying computing different characteristics, they would detect some directional patterns in the image. With the different filters, we would see a different texture patterns in the image. So immediately we come into point that from the perspective what the radiologists see, we represent image as something which human eye sometimes, well, cannot see. So for example, edges, yes, we can define edges visually. But the rest characteristics, we cannot do that. Like human eye cannot recognize it, especially in a quantitative way. So people were using, again, as I said, these hand-crafted features to characterize nodules. So for example, even pyridiomics library does this thing. It characterized nodules in 100 features, which later can be used in image analysis, in decision making. So, and here I want to explain how the particular features are computed. So operation to get all these previous images called convolution. So all of our feature computation comes from the convolution. So mathematically saying, so here on the left side, you can see what it means. The important part here is this little blue matrix. It's called kernel. Or another name for it is a filter. So by defining this filter and processing it with the source images, we define characteristics which we are focused on. So for example, as a previous image I was showing where we computed edges, for example, of the nodule. Here's a kernel or a filter which mathematically defined to detect images or edges. So how all of these things related to medicine? So because again, before it's simply kind of mathematical approach. So it's assumed that whenever there is a disease, for example, lung cancer or TB or I don't know, pneumonia, something. So this disease has a particular phenotypes. So through genetics, it's in characteristics which defined observable patterns in the behavior of the disease. So how the tumor will grow, how it will act, so how it will be represented on the image. So when we have it on the image, we can define characteristics which will highlight these patterns. So by defining these kernels or filters, we extract particular phenotypes or patterns in behavior which discriminate our population, again, in particular clinical, benign or malignant groups. So again, convolutional filter focus on target patterns. So for example, here is a sample from National Lung Screening Trial CT imaging, where there are two patients. On the top one presents patient where on the initial screening, it looks like, for example, similar to the patient below at the initial screening. So even though it's visually look similar, there is a difference that, for example, in the follow-up imaging, after 1 year, one nodule looked the same, and it diagnosed as benign. However, the second nodule, even though initially it was looking the same as the first patient, in a year, it progressed, and it was already diagnosed as malignant. And even though, as I said, initially it looked the same, if we start computing particular characteristics quantitatively, we already see a difference in quantitative values. So, but it leads us to the question. So, for example, as I before said, the characteristics which we computed were manually defined, handcrafted features. And then, well, how do we know that the characteristics we chose are the best? Or even in the set of features which we computed, how do we know that they are the best to discriminate benign and malignant nodules? So with this, we come into deep learning. So deep learning has quite of a big structure, but each part of this architecture has a particular role. So at the end here, first, we see neural network. So neural network is responsible of making a decision. So as, for example, we before talking simply absolutely the same way as logistic regression does, but with more sophisticated capabilities due to iterative layer-to-layer processing of characteristics. But as addition to that, we have convolution computation of image characteristics, which embedded into the model. So now it's not the weird computed characteristics of images. The model itself tries to adapt to the data set so that it's by itself find the characteristics which are important in the data set to discriminate the types of images. So the biggest difference I want to point out here that, for example, if here I showed only 3 aspects which we defined to characterize an image, our model will see hundreds, thousands, and maybe even millions of characteristics. So if radiologists see a single image, then the deep model see such kind of a texture, patterns, different characteristics, millions characteristics of the image. So it's a dramatic difference and sensitivity which differentiate radiologists from the deep learning. So here it's filtered out, it learns to filter out important features. And then the model by itself computes relationship between the characteristics and giving us the result. So with this, we're coming to the point. So where the medicine is here. The good thing, or maybe the bad thing, I don't know, but AI, from the perspective as I show you, doesn't know about the medicine anything. It doesn't know about abnormal mass, normal mass, lungs, hearts, what's the role of these, how they function, their structure. The model doesn't know anything of this. AI only looks at these characteristics which it extracts from an image. Nothing else. And it's really good at this, way better than the radiologists at that point. But it still relies on a particular data, on the data set which is presented here. With this, I'm coming to the consequences of using AI in medicine. AI, due to its sensitivity, can see characteristics of multiple things. So for example, it can characterize the disease. It can see the difference between patient sex. It can even see the difference through the medical images in patient race, patient age, but not only biological things, but for example, difference in the scanner type. If we, for example, change the acquisition parameters, if we have a CT scanner, and if we change the acquisition parameters in the scanner, we visually, looking at the CT image, we cannot say what scanner or what acquisition parameters were used. But the deep learning, due to the fact that it's looking at the millions of characteristics of images, it does see the difference. Simply even later, if we manually later modify particular images, again, AI will see these differences. It will see the artifacts and simply God knows what else. Simply by the fact, again, it's looking in a way deeper aspect that the human being able to. So it is a good thing, because if we can, if we are focused on disease, obviously AI will be really efficient to discriminate the disease. It can associate particular characteristics with a disease. But here's also problems, because it sees so many aspects, it's very easy to end up in confounders. So for example, if multiple hospitals are used in the study, and hospitals do use different scanners, and there is a correlation between hospital location and disease distribution, from the fact that AI has no domain knowledge in medicine, it will simply associate scanner type with the disease or the decision. But in a contrast, because it has no domain knowledge, AI can be used pretty much at any kind of a question you can think of. It can be used as a study, for example, in histopathology images, in X-ray images, in MRI images, and PET images, because we're not limited with the domain knowledge, like, for example, with the people, like with a clinician, like, okay, we have a radiologist, so radiologists work with radiological data. AI can work on any type of data. It's not limited for this. But a critical aspect here, we need to think of the confounders. With this, I would come to the point, the biggest difference what I would see is that AI is not the replacement for the healthcare professionals. It is a tool. The main point here is that, again, because AI doesn't know about the medicine anything. So it's really important to use it as for the study, for explanation, for revealing, do we have the signal, can we in general discriminate it or not? Finishing my talk, I would say that working with a deep learning, particular things are important. To be able to generalize results, you have to collect as much data as possible. Because with such sensitivity, model will simply learn to patterns in one or two patients, and it wouldn't be able to generalize it to the population. At the same time, to avoid confounders, it is important to collect as much information, clinical and even technical, as possible. And later, to validate if some of the information, again, clinical or technical, is correlated with the model performance, because it will be indicating that we have confounders. In order to avoid it, it is important to harmonize the data as much as possible. And I do understand that most of the medical staff will think about taking the same population, taking the same age or conditions, but it's also important to harmonize technically, because for the deep learning, it's absolutely the same. These characteristics as acquisition is absolutely equally important as a clinical characteristics. And even after that, the important thing would be to validate data on some external data set, which were never used in the training data set, to kind of, again, validate and verify that we minimize the risk of confounders here. With this, I've finished my talk. And do you have any kind of questions here?
Thank you very much, Dr. Dmitrii, for this very informative presentation. I'd like to request that we keep posting our questions in the chat. And also, like I mentioned at the beginning, we'll have a chance for people to speak up. They'll be given a chance. If you can put up your hand, you'll be given a chance to speak up and ask your questions or give your comments. I'd like to request that we move to the next presenter. Dr. Dmitrii, I hope you'll still be with us to respond to questions that may come up at the end. So allow me to introduce our second presenter for today's Day of Lung Science. And this is none other than Dr. Harriet Kisembo. She's a senior consultant radiologist and the clinical head of the Directorate of Diagnostics for Mulago National Referral and Teaching Hospital. She holds a bachelor's degree in medicine and surgery, as well as a master's degree in diagnostic imaging from Makerere University. And today she will be taking us through artificial intelligence and pattern recognition. You're welcome, Dr. Kisembo, to give your presentation. Thank you.
Thank you very much. Can you hear me?
Yes, we can hear you clearly.
Okay. Let me first close myself in. Good evening, everyone.
Good evening.
I'm glad to do some presentation on a topic which is also, I know, new to many people, though it is not new, but in our setting it is new. But at least it is really coming up and we need to embrace it. Thanks, Dmitrii, for simplifying or enlightening us on the background of AI. I'm going to briefly talk about lung cancer and the AI. And Dmitrii has done the background, so I'm not going to go so much in detail, but AI has a role in diagnostic imaging. In particular, now we are looking at lung cancer. So AI is useful in early detection and screening of early lung cancer, which may be missed by human eyes. And in this particular one, we use the low-dose CT scan. The dose is very low compared to the conventional CT scan. And as Dmitrii said, we look for nodule characterization. AI can differentiate between benign and a malignant nodule by looking at the size, the shape, the texture, the growth pattern, change with time. And with AI, there is a reduction in false positives and unnecessary biopsies. It can do risk assessment. It can look at characteristics, for example, of a nodule, then patient risks like smoking, genetic formulation, and then it can give us a risk assessment. And then you can personalize the scanning protocol, and you can personalize the screening protocol so that you don't have to do unnecessary screening. And AI is important in enhancing diagnostic accuracy, treatment planning and monitoring and the follow-up of patients. And there are several, it works like a flow, the way a radiologist is faced or a clinician is faced with a patient. You have multiple inputs, laboratory, clinical assessment, imaging, and then you can get you come up with a risk assessment. That's the flow of patients. I mean, the flow of AI, the way it works, computer-aided screening, you have biomarkers, the patient's history, the imaging, can assess cervical, and then also the screening. This is almost the same, the end-to-end, the way we work in a clinical setting, the workflow of a radiologist with multiple steps when you are doing cancer screening. Particularly, I'm looking at the patterns of lung cancer using AI, what can be detected. In imaging, especially we're looking at low-dose CT scans, PET, and also X-rays. So the patterns commonly which are detected, the nodule patterns, you can look at the growth pattern, the textural, the vesicular patterns, the lymph node patterns, airway patterns, metastatic patterns, and molecular and genetic patterns. So for the shape, I think Dmitrii talked about it. AI, you can look at the shape of the nodule. Is it round or irregular? The size and irregularity tends to point more to malignancy. And also growth over time is also indicative of malignancy. So that's why it is important for clinicians, which is not so in our setting. Previous imaging is very important if you are to come up with useful information, because you may scan a patient with a nodule, but if you have previous imaging, you may be able to relate what is the growth rate like. And then also Dmitrii talked about the edges. Are they smooth? I'm looking at this nodule. What are the edges like? Are they spiculated or irregular? So, for example, I don't know if I have a pointer. So, so there are the, for example, if you look at the first X-ray here, human eye, you may see it is a normal, but with the AI, you are able to pick a small nodule, which may be missed with human eyes. And then CT, you are able to pick the nodule. You are able at AI, you are able to look at the margins, the surrounding structures, and come up with a risk assessment. This is also an image of a nodule. Sorry. An image of a nodule. So I'm getting a pointer. Yeah, an image of a nodule. And with AI, you are able to assess the risk assessment by looking at its size, shape, surrounding structure, texture, and the densities. And AI can differentiate between benign and malignant nodule. For example, on my left, there is this nodule, well-defined and is benign. When you look at this nodule, you can see the margins are irregular. And then this one is a normal CT. So at AI, we are able to tell that. This is an example of a nodule with spikes or spiculated margins, very classical of a malignant nodule. So AI, you can determine the growth pattern. Rapidly growing nodules are highly pointing to malignancy, and also the invasion patterns of the tissue or the nodule. If you've seen a nodule, how it is behaving with the surrounding structures can point to whether cancerous or benign. And cancerous nodules tend to infiltrate the surrounding structures. Yeah, here we have some examples of AI and so lung cancer visceral pleural invasion. On human eye, I think you saw an example Dmitrii showed us that on a CT or conventional CT, you may not tell the pattern or how the tumor is behaving with the surrounding structures. But with AI, you are able to tell the infiltration, and the precision is 76%, Pakudo and his colleagues in that study, and sensitivity was 76% and specificity. AI is able to assess texture patterns, density variation. AI can analyze the texture and density of the lung tissues, identifying areas where there are abnormal changes. Malignant tissues often show a different structure or texture compared to benign. Then there are ground glass opacities, which can be a sign of early cancer, and this can be detected by AI. Vascular invasion. Of course, for the radiologists, you may see the obvious, but early detection of vascular invasion, which is very important in staging, can be detected by AI. And cancerous growth often stimulate the new blood vessel formation, which what we call angiogenesis, which I think in our research, in the current ongoing lung cancer research, Dmitrii, I think they are using it. And then the vessel displacement or compression, AI uses all those features to come up with the risk assessment. This is just a diagram of the tumor invasion. If there is invasion of the vessels have walls, so that tumor cells can invade from the outside up to the inside. And AI, you are able to detect all this, which you may, like in the number 5, you can see the invasion of the tumor all the way. This can be detected by AI, which you may not see at using radiologists. So, like for this CT, we can see this invasion, but this is like an obvious one. But early detection, AI is able to do that. Lymph node patterns, still AI, we can detect enlarged lymph nodes in the chest, which may indicate metastasis. Then the distribution of the affected nodes, which is important in staging. So we've already gone through how AI interprets or the deep learning training, how they interpret and they internalize the feeding data, and then we are able to pick nodal lymph node involvement. Airway patterns, AI can detect involvement of the trachea, the bronchi, or the airway, which sometimes is in advanced stages, may be associated with collapse, lung collapse. Sometimes even we may see on a CT or X-ray lung collapse, but even you don't know why is this lung collapsed. But with AI, you are able to see the extent, the invasion of the tumor into the airways. Distant metastasis, yes, this can be picked and spread, and this helps in predicting the assessment risk. This is just a diagram of staging, cancer staging. Here you have a tumor which is less than 3 centimeters, stage 1. If it is 3 to 5 centimeter, stage 2, and the regional lymph nodes. In stage 3, you can see the tumor is over 5 centimeters, and then the affected regional lymph nodes. And of course, stage 4, you have metastases. MRI, molecular and genetic patterns, and so you can get blood samples, which I think we are doing the biomarkers to determine the risk or assess the risk involvement. This was a case I came across, and whereby a 45-year-old male heavy smoker for 10 years, taking like 20 cigarettes. So history is important. One of the data which can be used by AI. So this patient underwent PET CT scan using also nuclear medicine, and then was able to detect the cancer. So it was a screening CT. You could see that tumor in the upper lobe, and then there were metastases in the. There were metastases. There were lymph node involvement, and and the AI was also very important in detecting or the staging. And then the pictures below, it was for a follow-up after chemotherapy. We can see this tumor is less than this one. It was only the node involvement which increased in size, but the rest of the tumors, there was also a brain one, which we don't have here, but all of them reduced. So AI was involved in follow-up and monitoring of the patients. So I think I will not go so much into advantages in the interest of time, but there is increased sensitivity in detection of subtle features which may be missed with human eyes, and this, of course, will determine the outcome of the patient. Early detection, of course, with better outcome. And then efficiency. AI can be used to, it can, like if you have workload, over workload where you have inadequate or human workforce, AI can be used to screen out the patients who are at high risk, and then triaging patients, and then enabling faster intervention for patients who most need like screening. And of course, it can be personalized depending on the patient's symptoms, and so many advantages. People can read about them. So in a resource-limited setting, like our setting, of course, AI is important, like in telemedicine. AI diagnostic can be integrated within telemedicine platform. It can be used in portable and low-cost imaging solutions, and where human resource is, like in Uganda, I think we have maybe less than 100 radiologists. And so AI can be very cost-effective. Challenges, data quality and availability. Of course, that what you put in these models, Dmitrii talked about them, the data we put in will, of course, affect the accuracy and reliability of the AI tool. Okay. Of course, in a low resource center, our data is terrible. I think we are really facing it. Data, we don't have data culture. We don't keep our data. Quality is not good. So what we feed in the model will really affect. And then, of course, infrastructure and the power maintenance like internet, they are a challenge. Of course, the model culture and the language barriers, ethics, data privacy, all those are things we need to look at. In HIV, the research we are doing has also cancer in HIV. We know that patients with the HIV have high risk of lung cancer. So the model need to be maybe tailored to HIV. So this will be a typical presentation. Patients will present with a typical presentations. So you need to have a model which is tailored to a patient with HIV. If you use it on an ordinary model, it may not give you the proper or accurate information. Then comorbidities in Uganda, I think our research is going to give us important information. We have TB, those comorbidities, HIV, TB, they all can affect or can be affected by the model, the type of model. So AI must be able to differentiate lung cancer from all these other comorbidities. In conclusion, the future of AI in lung cancer screening is geared toward more precise and personalized and accessible healthcare. AI will continue to evolve, enhance early detection, optimizing screening programs, and integrating into clinical workflows. Potential to significantly reduce the burden of lung cancer widely. So this is just, I think, just an overview of patterns, but there's a lot there, and there's a lot we need to learn. But I think AI has come, we need to embrace it. Thank you very much.
Thank you very much, Dr. Kisembo Harriet, for this presentation. I believe there is a lot that we have all learned from the two presentations that have been made this afternoon. We're going to give an opportunity for people to put up their hand and ask questions, but also if you prefer to post your question or comment in the chat, please feel free to do so. We have a CPD link in the chat. Kindly register your attendance there. Maybe for our colleagues that joined us along the way, I'll just try to summarize the key points. We started with an introduction to AI by Dr. Dmitrii, and we have learned that artificial intelligence is the ability of a machine to to imitate intelligence. We have learned that artificial intelligence requires training with input of data through that various processes of the computation, convolution, and finally you're able to get an output. We have also learned that artificial intelligence does not know what medicine is. It doesn't have that knowledge. So the knowledge it obtains is through continuously feeding it or inputting data into the machines and the machine learning. We have also learned that artificial intelligence doesn't know anything before and after training. So it works with what we feed it with. It extracts data or information from images it's fed with, and it relies on the data or the images that it's fed with to be able to give us information to make decisions. We have also learned that with artificial intelligence, we have to collect as much data as possible. we should be able to also collect as much corresponding information as possible. And we should also try to validate artificial intelligence with external data. Then from Dr. Kisembo, we have learned about the application of artificial intelligence and the different patterns of recognition. We have learned that AI has a role in early detection and screening of cancer. For example, we have seen how it can be able to diagnose malignant to differentiate benign from malignant nodules. We have also learned that it can help us to reduce the false positives during our screening of patients, as well as decrease the unnecessary need for biopsies among patients. It helps to do risk assessment and stratification of patients. And we have seen that it can use different images from CT scans, from PET scans, from X-rays, which would be the data sources in this case. And we have seen that it can detect nodules, it can differentiate benign from malignant ones, it can detect the growth patterns or rapidity of growth of these nodules to help us appreciate whether they could be malignant or not. It helps us appreciate the invasiveness of these malignant nodules, invasion of vessels, metastasis to nodules, among others. We have also seen the airway patterns that can be detected by artificial intelligence. That's the bronchial obstruction, airway invasion, and the rest. We have seen that AI can also help to identify the molecular and genetic patterns, and also help with staging. We have seen advantages of AI, that's early detection, improved diagnostics, better accuracy, and also the benefit in low resource settings, where it bridges the gap with the low numbers of the specialists in low resource settings, enhancing access to diagnosis. We have seen challenges such as poor quality of data, infrastructure challenges like power and maintenance challenges. Yes, I think that's what I've been able to remember as went along. And with this, I would like to open the discussion. Kindly, if you'd like to be given a chance to speak up, please feel free to put up your hand. And if I can check in the chat. So we shall have questions to both the presenters. Kindly specify who you'd like to respond to your question. Looking at the chat, we have Joan Navachwa. She's thanking you for the presentation, and she's requesting you to kindly comment on patient privacy while using AI. I think this will go to Dr. Kisembo. And then from Oronon Pius, says that this sounds interesting and leaves us hopeful for better outcomes and health coverage. However, he's wondering how AI implementers ensure privacy of patients, since this may be owned by other countries and not necessarily Uganda. He's wondering whether there are biases expected and how these biases can be addressed. This goes to, so the first question on privacy and confidentiality goes to Dr. Kisembo. Then the second question on the biases with artificial intelligence goes to Dr. Dmitrii. And then the third question we'll take. So I think I'll just capture these three, then we can respond as we wait for more to come up. So Joseph is asking that during model construction, can every radiological center in the center be a center for development of AI locally? Yes, could you kindly respond to those, Dr. Kisembo and then Dr. Dmitrii? Thank you.
The second one was what?
It's about privacy and confidentiality of patient information, and also whether local radiological centers can be involved in the development of artificial intelligence in our country and the development of the AI models.
Of course, starting with the second one, of course, I think Dmitrii said these models, to build these models, you need a lot of data. and it should be representative. You don't just get data, let's say, from one part of the country. It should be representative data. So if there's a model being built, they should be involved. Patient privacy and data, of course, is very important. And in fact, there was somewhere where I read that, for example, if a wrong diagnosis is got, who is responsible? Is it the hospital using the machine? Is it the AI which gave a wrong diagnosis? So, so privacy, I think there must be regulations on patient data, and the way things are moving, we are looking at collaborations. I think that's one of the way forward. Collaboration, global data sharing initiatives are on the way, consortiums and research networks. So I think these are the issues to look at. There's a lot of data sharing between institutions, between universities. So we need to look at this. Maybe Dmitrii will comment on it. And then also, they must be regulatory framework. So as AI becomes an integral part of lung cancer screening, there is a need to have regulatory frameworks which protect patients and also the technology as such. Maybe Dmitrii can guide us if there are regulations and also on data sharing. I know collaborative research, we normally sign data sharing regulations. So I believe even AI, they are there. But I think when you are capturing patients' data, you don't capture their names, their identities, of course. But Dmitrii can guide us, throw more light on that. Thank you.
Well, in addition to the privacy, I think there are two aspects important to note. The first is that, well, during imaging, all the images are stored in DICOM format, so that clinical information, so-called PHI, so protective health information, patient name, sex, age, address, treating doctor, radiologist, is stored in the image. So image, besides the visual information, also has so-called metadata. So it does have there. So one of the steps of preventing spread of this information is the identification, where patient data removed from metadata. So that's one thing. Second, it's a more complicated question. It's because the image itself has information about the patient. So for example, if you do MRI of a patient, you do an image of his face. I mean, there are tools so you can reconstruct the face of the patient. And simply, who knows what other information can be retrieved from the images. So the second question is, again, kind of a complicated, and it's still open. So that's about the privacy. So the question, are there biases expected, and how can biases be addressed? Well, first of all, pretty much any kind of variability, let's say, not associated with a disease, and sometimes even with a disease, might be considered as a bias. And it's an open question. At some point, I would say some of the biases, as I said, let's say variability in scanners, well, they're probably impossible to overcome, because if you do imaging with different scanners, well, that's what you have, and that's will change your representation of an image. Here, to overcome it, you simply need to harmonize acquisition protocol for the study, which is sometimes it's not as easy, but at least at some degree to address this question before the study. Second, there is all, for example, studies where was a prostate cancer, when the research design diagnostic or prognostic tool, I don't remember exactly, and the study was mainly done on the white population, and then they start using the same model on Black African American population, and it didn't work. So the idea is it somehow racial or sex status of a patient define the development of the disease? Is it different across races? Is it different across sexes? Is it different between the different populations? So if yes, then probably again, you need to simply specify, okay, this model works for this population, this model works for that population, because right now, again, in the literature, there are works saying that, well, deep models are not good to generalize its performance in such cases. So I think that's the second part.
Thank you. Thank you very much, Dr. Dmitrii and Dr. Kisembo. We have a few other questions in the chat, but maybe I could also ask mine at this point since I have the mic. So one question, I have a few, maybe 2, 3. But my first question is to Dr. Dmitrii. You mentioned that for machine learning to take place and for us to be able to have good outputs, you must feed the machine with as much information as possible, as much data as possible. So the question I have for you on this is, how much is much? Like how would you be able to tell that now the machine has been fed with enough information and it has been able to learn? And then my second question still goes to, I think it's to both of you. Sometimes you're going to get an image with multiple abnormalities. For example, you may have an image with a nodule, but also maybe has infiltrates, has a pleural effusion. So if your focus is on making this machine learn about the nodule and then the characterization of the nodule, how are you able to condition it to ensure that it does not focus on the other abnormalities on the image? And then my third question, which I think may be my last, can artificial intelligence use other data other than images? For example, if the result or the data that you want to feed it with is a printout of a result, can that also be used as an input to be able to build a model? Thank you.
Okay, so
Sharon, I can also add my question there.
Yes, please. Yes, Prof.
I'll make it brief. Is Dmitrii took us through how AI uses or builds on simple logistic regression to create these models that can be able to tell the pathology. But what I wanted to know is, does AI improve these equations in the process? Because as we know from statistics, logistic regression has so many limitations, especially as it regards the number of variables you can add. I don't know whether Levi, the biostatistician, is here. So does AI overcome these things, or it is what we get is the same?
Okay, so the first question was how much is a much, and then again improvement of AI. So answering the first question, how much is a much? I would say the better, the more the better. However, talking about, let's say, lower bound, 3/500 of patient is something I would say more or less enough if we would talk about machine learning. So let's say statistical approach or similar to statistical approach. For deep learning, it would be better to have number something like starting from several thousand of patients. That's the answer for my side for the first questions. Second question, does the AI improve kind of statistics because like logistic regressions has so many limitations, et cetera, et cetera? The main benefit of the AI is ability to find connections between multiple variables. At that point, I would say. So similarly, if you have logistic regression, it will be one story. And simply, okay, let's say we have longest diameter of the nodule. So most probably verifying results of like risk group, if we give the AI only longest diameter of the nodules, so most probably we will come up with the same results which we see now. So it will kind of reproduce the results we see. The benefit of AI is like we can introduce more information where for a simple human being to find a relationship between these variables, these characteristics will be complicated. And AI, due to its speed of computation, simply will be able to analyze relationship between multiple characteristics faster. And due to that point, might improve performance. So here's the answer for my second question.
Okay, thank you very much, Dr. Dmitrii, for those responses. I think the other two questions go to Dr. Kisembo on how you can uniquely pick out particular pathology and ignore the rest in the background. And then whether machine learning or artificial intelligence can use other data other than images.
Yes. Of course, this was on diagnostics, but the AI can use patient information It can use the lab, blood samples, biomarkers, except now we are concentrating on diagnostics, and the AI is useful in mammography, which is imaging, TB, all those are images, but I know there's AI language recognition. AI has been used in the language recognition, and also I think fraud detection. So it can be used in several, not only imaging. Differentiating, I think different models, as we said, the machine will interpret depending on the information you feed it in. So if we are interested, like now we are interested in screening, meaning early detection of lung cancer. So in our setting, somebody may have lung cancer, but he has also maybe previous TB. So you have those granulomas, but this patient also has maybe early cancer. For that, AI can detect. Then I think by the time somebody has pleural effusions, big tumors, I think that is an obvious. So what we really want is early detection. So is determining whether this effusion is due to TB, or I think it will use other signs like lymph nodes. And when you do PET CT and the AI, then it can determine between a malignant lymph node and a benign lymph node, a tumor invasion, and benign nodules due to TB, or benign nodule, malignant nodules. So mainly AI is to early detection and screening. So that's why we're really very useful in mammography for breast cancer and also lung cancer. So briefly, there was in chat somebody, I think Mary, asking whether we have whether AI has started being used at Mulago. No, we don't have. But I think it will be a very good innovation for low resource setting. But I think Ministry of Health used it for TB screening. They used it for TB screening. So it's on our way. Yeah, thank you.
Thank you, Dr. Harriet. It's true, actually, that the National TB Program is using AI to interpret X-rays for patients being screened for TB. And this is actually being used by the program even to date. So we are happy to see that this is coming up in diagnosis of other conditions. So we have one more hand from Ted, and I think that will be the last comment that we shall take in the interest of time, because our time is fast spent. So over to you, Ted.
Yeah, thank you very much. It's a very good discussion. For the first speaker, I was wondering, how do you determine, usually in statistics, we want to apply power analysis for detecting any significance or prediction. How do you determine power analysis in machine learning or in your deep learning and avoid overfitting or some other thing that we don't want to see? Is there any power analysis that you follow, or can you comment on that?
Yes. So usually one of the standard approaches of overfitting, well, one of the approaches to avoid overfitting is embedded into the training process itself. So it's not done by power computation like prior training, but as I said, it's in the training itself. So for deep learning, for example, the data is split into three parts. So the first part called training data, which is used for training of a deep model. The second part is so-called validation data. So it's not used in the training, but after each iteration of training, the model checks its performance on unseen data, which is indirectly used in the training. Because again, it's not used directly to train the model, but the model tested during training on that data. And what's going on is that whenever we see that on the validation data, our performance start decreasing. So before it was improving and now it's decreasing, when on the training data, our performance is still increasing. So we kind of see the fork. So that's a sign that we have a overfitting and we should stop our training. So that's how we avoid the overfitting, for example, for deep models. And later, it's the model is validated on the third data set, which is test data set, to report its performance.
So the question is that maybe I can rephrase it. Is there any power analysis followed, and is there any minimum number to run this kind of work?
Again, no. As I said before, it was mentioned, like it's pretty much unknown what's the minimal number. There is no such kind of threshold. You can say like, well, okay, you have 200 patients, it's not enough. You have 210 patients, it is enough. It really depends on architecture. It really depends on how many weights. It really depends on even what we apply, etc., etc., etc. So it's generally saying agnostic way of looking at this, like approximately empirically defined numbers, because there is no way to define like, okay, we have this model, that's how many patients we have to have.
Thank you.
Thank you. Thank you very much. We have had a very interesting discussion this afternoon. I believe we have all learned a thing or two. Actually, we have learned a lot because this is a new area for very many of us. So once again, I'd like to appreciate our experts for today's session. That's Dr. Dmitrii and Dr. Kisembo. We appreciate you sharing your knowledge and your expertise in this area. And we hope to have more of these discussions with you going forward. I would like to appreciate everyone that has participated in the discussion, but also made time to attend and learn from this session. And at this juncture, I would like to end our session. We have gone over an hour and a half. I appreciate you for staying this long, but it also means that the discussion was interesting. That's why we kept on. So thank you very much for attending, and I welcome you to our next Day of Lung Science session that we shall have on a date that will be communicated next month. So thank you once again, and have a good morning and a good afternoon.
Thank you.
Okay, bye. Bye, everybody.
Bye.
Bye.